Oh, thank you very much. So I think the topic, I would say, needs no introduction. Everybody is familiar. So these are my conflict of interest. We received equipment from Fisher Paykel, who is doing this equipment. So again, it has become familiar to everyone that with the high flow technique, you can control the flow and the FiO2. You warm and humidify the gas. You deliver with a non-condensing tubing, so you have no water directly coming into the lungs. And you use nasal cannula. And we think that there are more or less 4 potential advantages. You match patients' inspiratory flow, and the FiO2 is stable, which, by the way, makes sometimes interpretation of result in studies a bit complicated because you see a better PaO2, FiO2, but it may be simply better because you have a higher global FiO2. There's this low CPAP effect, lung recruitment. I will discuss that. And we all know, we have measured that when the patient has the mouth open, there is no positive pressure. So it's a bit strange that it seems to be a CPAP effect without positive pressure. There is a very good humidification, which is the only reason why patients can tolerate high flow. It's absolutely intolerable to tolerate cold flow, high cold flow. And if by mistake you forget to switch on the heater humidifier, the patients will worsen very quickly. So that's good to know. And the last thing is this washout of dead space, which is really a very, very nice concept. You expire CO2, and this is what you re-inspire at the next breath. And if you have fresh gas during the whole inspiration, at least what you inspired at the level of the vocal cords is fresh gas. So you decrease this part of the dead space. And this is a very unique way to decrease the work of breathing. All other techniques either improve mechanics or add additional support. This one decrease your needs or decrease the needs of the patients. And this is a really interesting one. And we have data. This is one study from Tommaso Mauri on the right. You have the pressure time product, which is let's say the energy consumption of the respiratory muscle over 1 minute. And I think this point over 1 minute is important because you will see that the respiratory rate plays a very important role in the effect on the work of breathing. So just to mention some of the data we gathered, there is another mechanism which I think is important with high flow, which has not been really very well described, which is the possibility to increase airway resistance. This looks very counterintuitive because you say this is bad if you increase resistance. So we did a quite complex study, and just this illustrates the fact that we compared the different rate of high flow, 20, 40, 60. We compared mouth open, mouth closed, and we compared to CPAP to see whether there was any difference with CPAP. And it's hard to see, but if you look at the flow, the higher the flow, the lower is the volume for the same effort. This was a simulated study, and then we did in healthy volunteers. And we calculated this inspiratory and expiratory resistance. And especially for expiratory resistance, it's clearly much higher than CPAP, for instance. So you expire against resistance. And I think this is, for instance, if you look at the classical physiology studies, the response to increased expiratory resistance is lengthening of the expiratory time. So I think this is the main explanation why the respiratory rate decreases. And you may have seen, if you do it on yourself, it may be spectacular. You may keep a very long expiratory time. And why is this important? Because if you decrease respiratory rate, you and if you don't increase your tidal volume, you decrease minute ventilation, and this may be the main reason why you decrease your work of breathing. So two effects combined. One is the washout of the dead space. One is this increased expiratory resistance. And there are very nice experimental studies who show that if you increase the expiratory resistance, you keep the lung open more for a longer time, and you decrease lung collapse. So it may not be the PEEP effect that we describe, it may be this effect of the expiratory resistance, which, however, is also lower if you open your mouth. So again, that's important because in the future, if we know that we have these different mechanisms, the pressure, the flow washout, and the expiratory resistance, with different types of cannulas, we may have different respective effects, right? There is now an asymmetrical cannula which is being tested, and you have also in the literature interesting reports where people used a single cannula, just one nose. So I think we'll know better in the near future. Just to remind that there have been a lot of studies, and then this was very rigorous guidelines led by Bram Rosberg and Karen Burns, and I will mostly focus on the hypoxemic respiratory failure. This is how I think the number one indication. It's really very, very highly influenced by this study, which has not been reproduced so much. We have some positive studies, but many are not that positive, and which was a bit a surprise, I would say, because if you remember correctly, this was comparing three techniques: NIV, high flow, and just nasal oxygen in patients with mostly community-acquired pneumonia. And the question was, does it decrease intubation, which may turn into better outcome? And the answer was no, because the primary outcome was in every patient with PF below 300, there was no difference. However, there was a difference in the subgroup of patients who were most hypoxemic, PF below 200. I'm saying that because maybe if we address the question raised in the preceding talk of overuse, maybe sometimes it's overuse for patients who do not need it. But what was really fascinating in this study was that for the whole group, this is now taking into account PF ratio below 300, there was a difference in mortality, in survival at day 90. And you see there was no effect of NIV by itself. So, which really is interesting and important, if true, or if reproduced in the same conditions. And it raised the question, why would patients survive better, even without less intubation? And that's one possibility, which is that because you decrease minute ventilation, you decrease the risk of patient self-inflicted lung injury, for instance. So we use it a lot. This is the data of the systematic review and meta-analysis, and you see that in general there is clearly, it's impossible to read, but there is significantly less intubation. It's more difficult to show a difference in survival, and it's a technique which has been used a lot during the COVID-19, and we used a lot, as I guess many people. There has been a lot of data suggesting it could avoid intubation. This was at the beginning of the pandemic. It's an emulated trial, so it's not a real randomized trial, but you take the observational data and you try to adjust for differences, and there was significantly less intubation in the group treated with, or I'm showing the oxygen mask. This is more intubation and less intubation in the high flow. And there was at least one randomized control trial which was performed in Colombia, very well done, and they found that there was significantly less intubation. Sorry for that. Significantly less intubation and a better recovery. no study showed the difference in mortality, right? But however, if your patient can be discharged from the ICU without being intubated, I think both the patients and the team would be happy. Just one point to say, because it has been so much and so frequently, people now are saying, well, there was a lot of patients we would normally call ARDS who were in fact treated with high flow, which may be true, and there is discussion about whether we should expand the definition of ARDS, at least for the trials. And the data here from Marco Ranieri suggests that most patients who have a PF below 300 under high flow after intubation, for those who are intubated, still have a PF ratio below intubation, below 300. So saying, well, these are the same patients, but before intubation, the actual definition makes it difficult. I don't know whether it's really important for most clinicians, but it may be important for future trials. Just another big indication, and I'm not going to go through all indication, is post-extubation. I think it has showed that it could help. Some results are a bit puzzling because we see that it seems to be very efficient to prevent reintubation, even in low-risk patients, which is still a little bit hard to introduce into practice. It is not shown in all studies, and for instance, this study by Arno Thiel, multicentric, showed that high flow plus non-invasive ventilation was more efficient than high flow. And in a post-hoc analysis, it showed that this was true in the overweight or obese patients. Overweight meaning just BMI 30 or above, so that's a lot of patients in the ICU. And the data suggests that non-invasive ventilation combined to high flow is better. And so that's how we use it, for instance, in our ICU. Just to mention that not all studies are positive. This is a very nice study done by Rino Maggiore, who found no effect on reintubation. There was just less crossover to non-invasive ventilation, if you want, in the group treated with high flow. So the studies are not so strong in intubation, and it's a little bit difficult to define what are the limits. Okay, just a final word to say it's tempting to use in chronic CO2 retainer coming to the hospital because of the CO2 washout. We have much less data. In our center, we have a lot of adult patients with cystic fibrosis, so we did this study which showed that in stabilized patients, it could be used as an alternative to NIV. And that's good for this patient because it's really hard sometimes to tolerate the mask for a very prolonged period. In COPD, very few data. This is a nice study from one of our previous fellows from Toronto, Nutapol Ritayamai, who did that in Bangkok. He progressively increased the flow rate, and he found that he could come to a work of breathing equivalent to BiPAP. Interestingly, in some of the patients, when increasing the flow above 30, he found that the work of breathing increased, suggesting maybe this mechanism of high resistance is not so well tolerated with higher flow. And I think we need to learn a bit more. Do we need a different adjustment in these patients? And I think the NIV for patients who are with COPD exacerbation is still the best first-line treatment. But it could be maybe you could alternate with high flow. So these are systems which provide really optimal humidification, and that's a great advantage in terms of comfort. It works like an internal assistance, and I think it can be the first-line therapy in hypoxemic respiratory failure, but its use in association with other techniques may be interesting. Thank you very much.
Thank you very much. Yeah, there's a question at the back of the hall. think there's a microphone coming.
Thanks so much, Dr. Brochard. I guess I have two questions that sort of factor in from the last slide that you gave about the study that your fellow in Bangkok had done. So one of the questions I often face is how to figure out what the settings for high flow that we should opt for might be. And Dr. Randolph had mentioned how they have a nice protocol and there are a couple of studies. And so particularly with the questions related to preventative strategies on extubation to prevent reintubation, where I'm not really targeting something particularly physiologic about the patient. How do you think about settings there, recognizing our lack of data? And then secondarily, given your fellow's study, how do you assess work of breathing at the bedside so you don't run into that problem?
Yeah, so maybe the second one, this is a big issue because I think I'd love to be able to measure work of breathing in many of my patients. I think this is the best indication for intubation, and this is something we cannot measure. So the best we can do is estimate the activity, the tonic activity, the phasic activity of the accessory muscles. The respiratory rate, unfortunately, is not a very good indicator. Just to keep on this issue, I found interesting that there are several studies where, let's say, a surrogate of the effort is to look at the tidal volume, which you can measure when you put a mask and a ventilator. And that's interesting because, for instance, it predicts quite well an IV failure when it's really high tidal volume. And some people say, instead of the ROX index, which use the frequency and the SpO2, FiO2, we published a short research letter in the blue. They do 2 minutes of face mask to measure their tidal volume, and well, this is a bit experimental, but that's interesting. And lastly, another techniques people are trying is to put a small catheter in the nose. So you occlude the nose, and the swings may be an estimate of the esophageal pressure. Just to say, this is a big issue which we don't have a good solution. So that titration is an issue for the high flow. I think that was your first question. And I would say certainly ask the patient, and when going up on the flow, and sometimes the temperature is an issue also. So ask the patient about their comfort. And the respiratory rate in this case is specifically interesting because if you have so for two reasons, the bench studies, let's say, show that the higher the respiratory rate, the less efficient is the technique. You have less time to flush the CO2. And then when it works well with this expiratory resistance, you see this lengthening of expiratory time and decrease of respiratory rate. So again, it's not very detailed physiology, but I would say ask patients' comfort and look at the respiratory rate.
Okay.